went to see a patient here, and as I started to think about how to care for this patient for asthma, I thought, geez, I think there's these new guidelines out from the National Heart and Lung Blood Institute. I couldn't find the guidelines, but I sort of vaguely knew what I needed to do. I couldn't find anybody to help me to do the peak flows. I ended up getting through, as we usually do. But it took a long time, and I thought, this is crazy. So we did a chart review, and we looked at the key outcomes that people said we needed to track, and whether they had an action plan or a school plan, whether they had gotten a flu vaccine. And we showed that we were doing a horrible job. We gathered everybody together and said, how could we do it differently? All I really wanted was a stamp so I could put the peak flow. But then I had some people, and this is what made it different, I had people around me who believed in me and believed in the project, more importantly, and said, you know, I think instead of a stamp, why don't we just change the encounter forms? And you know what, Tori, you don't need to do that peak flow. What about the CNAs doing it? So then we were starting to engage people in this process. It became something bigger.
Quality became a serious concern for us in the late 80s and early 90s. We were sort of in the midst of the first wave of consolidations where some of the smaller practices were being acquired by larger groups. And we recognized that if we were going to remain independent, we not only had to be very good with regards to the way we ran our business, but we needed to be able to demonstrate that our quality was as good as anybody else in the area. And we decided we better focus on that a lot. Good morning, Joy.
Hi.
How are you this morning? Our first work was around diabetes. Very early, very simple stuff. Back then, we weren't even really working very hard on hemoglobin A1C as a measure, but it was more a matter of the frequency with which our patients came in and the controls that we had on them and standard expectations. Very rudimentary, very stumbling at first, even just getting a sense of why we had to understand what our systems did and not depend entirely on the focus and attention of each individual provider to get the right thing done. Our principle was that whenever we found ourselves saying, well, we just can't do that because of X or Y or Z, we would say, no, we're not going to accept that principle, and we're going to find a way to get it done.
Here for my 11:30 appointment.
Okay, is anything?
Since we've gone into the electronic medical record, it's made a world of difference. The staff was very reluctant at first, and possibly since they hadn't had so many experiences with me yet, they were willing to consider it. But we also had people come down who were implementation experts, and so a lot of the initial work they did was to try to make everybody feel comfortable. This wasn't the first time they'd done anything like this. Other staffs had done well and enjoyed it afterwards. And then the staff became a part of trying to plan the implementation. What kinds of medicines would we use, and what kinds of workflows would we have? So each of them, I think, had a little something that they were promised they would be getting out of this project.
I'll go get that meter for you so that you'll be able to talk it over with Dr. Holbrook. Okay.
We found that after a week, the patient demand was so great that we were really going full gun and seeing patients just like we had before, and we were electronic.
We were able to apply for a grant from Partnership for Quality Education. And this is where you were able to take your quality improvement projects, I think, to that next step. And in that grant, it was to teach the chronic care model and the OP program into two other disciplines, internal medicine and family practice.
Take a listen to your heart. We first forged a really tighter relationship with the Health Partners organization, and in forging that relationship insisted that we became a part of ICSI. It was founded as a collaborative of 20 different medical groups in the area. Their resources were aimed at developing the protocols and developing best practices, but also building expertise in the member clinics so that they could do quality improvement. And so we set ourselves up as a small group in primary care practice, and knowing that we will be reported in a public way is a real powerful motivator, and we just love it when we show up in numbers that are substantially better than the Mayo Clinic is performing on all the different things that we measure. And we do it pretty consistently.
I think the first obstacle is what we hear all the time. Physician says, I can't do anymore. I can't do this. So we started with, hey, it's not about you. It's really about the patient. And we got a whole team. And did you know that now the CNAs are going to do the peak flow? And the docs would go, oh, that's nice. That may work. So we had to really take this model of, instead of the physician being the center of everything and everything sort of moving around us, that the patient was there and there was a team. And how do we engage the team?
There are economic barriers, and you have to be disciplined around establishing the business case for it, and then getting a pretty clear sense over time of whether or not it's delivering on that business case, so that you can answer those concerns over time, and so that you can make legitimate arguments to the payers about how you're going to need to have extra support for that.
I think an awful lot of doctors see the cost as something that comes directly out of their pocket, rather than costs that are amortized over a period of time, and also costs that also help to make the office more efficient, so that you practice better, and some of your costs go down, and the numbers of patients that you can see and do a good job with are better.
If you don't have a clear aim, if you can't state in a sentence or two what you want to do, you're never going to bring somebody along with you.
How about a big breath?
So we were able to get all of us together and say, okay, let's be specific. What do we want to do? We want to improve flu vaccine rates. And that was something internal medicine could buy, family practice could buy. So we tried to figure out what the messages were that would bring other people on board, which would then help us with our overall project.
You have high blood pressure that's run in your family.
We suddenly had an EMR that would do an awful lot of things, worked fantastic in the office, but try to call a pharmacy and fax in a prescription when they weren't ready to take faxed prescription, try to call the lab when they didn't want to have you sending over your form, you had to use their form. Each time an interface comes through, it's like a breath of fresh air. Suddenly a task is so much easier.